Hello, everyone. Thank you so much for joining us. We're going to take a couple of minutes and let people join our webinar. So as people enter, welcome. This is our 2022 PNHP Minnesota Annual Meeting. Welcome to all of our members that are joining us tonight. If you are coming to us from a sister organization, we thank you so much for coming and joining us. It should be a very exciting evening full of great discussions, and we're so happy to see you here. Before we get started, because of our format tonight, sadly, we're not in person. People don't get to see who has joined in our meeting. So feel free to open your chat window. The chat button is going to be at the bottom of your screen. Feel free to open that up and introduce yourself. Let everybody know you're here. If you're willing to do that, you can put your name. If you're here from a sister partnering organization, we would love to hear who you're here representing tonight. So feel free to put that in the chat window. All right, it looks like we have a lot of our attendees here, so we will get started. Welcome again. My name is Jen Crawford. I am the Executive Director of PNHP Minnesota. Thank you so much for joining with us. We have a jam-packed evening, so we will be here until 8 p.m. and every minute is full, so we're just going to get started right now. So the welcome message will be myself, and then I'll pass it over to Dr. John Crossan. He is our board chair, and he'll be telling us about 2021 and everything that the year brought for us. After that, we will talk about the year ahead, including awesome opportunities to get involved. We will hear from board members Carrie Carlson, Sarah Laura, and Dr. Jenny Zhang. Then we will have our keynote speaker, our presentation by Dr. Rachel Madley, who you will recognize from last year's annual meeting. She will join us once again to give us the State of the Union. She will talk about the national movement. She, of course, is the lead health policy advisor for Representative Jayapal. Then at 7:30, we will have a great panel discussion of public options, and that will be led by medical students Zelda Blair and Alex Jacobs. You will recognize them. They were summer interns with us here at PNHP. We will have closing remarks and a final call to action. And then we have decided that we're going to keep the webinar open after 8 p.m. There are going to be questions throughout the evening, and we want to make sure that we get those answered. So feel free to stay online after 8 o'clock to chat with our panelists. So tonight, while we're on Zoom, feel free to make your voice heard in this virtual world. To do that, you'll open your question and answer button at the bottom of your screen. It will say Q&A. When you open that, you can type in your question and click submit. You can submit your question anonymously, or you can have your name tagged to it. If you aren't interested in having your question answered, but you'd like to help direct the questions that we're going to be feeding to Dr. Madley and our panelists on public option, you can actually help do something called upvoting. If you open the Q&A button, you can click the thumbs up sign next to the question that you would like to have answered, and that will help us decide what we're going to be asking tonight. So with that, we're going to kick it over to Dr. Crossan, who will talk about the last year with PNHP. John?
Thank you, Jen, very much. I appreciate the introduction. And as Jen said, I am chair of PNHP Minnesota. We have had a very active year in 1921. We have had a number of educational events, particularly partnering with HCAM and with the Minnesota Nurses Association, which we're going to be doing a lot more of in the future. These are the three main organizations working for Medicare for All, particularly in Minnesota. And so we are moving much more to collaboration with these other organizations. Next one, Jen. We have a very active and aggressive summer internship program, which is extremely important program, and you'll be hearing from two of the summer interns from last summer. A little later on, we will be having a large summer internship program this summer. We will probably begin interviewing them probably in about a month. And the summer interns spend part of their time in education. We have a very strong educational program for them. And they also spend time working on different projects in healthcare delivery. And this is one of the main things that we do in our organization. Next. Last May, we were able to establish a panel discussion in the Essentials of Clinical Medicine for the first year medical students. This was a 3-hour panel that actually went another 45 minutes beyond that because there was so much interest in it. We have really made great progress in educating the medical students about this particular issue and getting them to actually back what we are trying to do. Next one, Jen. And this leads us into what we do with the student chapter at the University of Minnesota. It's a very active chapter with many, many medical students a part of this. And we're going to even be trying to expand it more this next year. Next one. And then finally, we have provided physician advocates to speak to a number of different organizations, including healthcare provider groups and some churches and so on and so forth. So we continue to be very active, and this is why we need your support for what we are trying to do. Can we move to the next slide, Jim? This is what is really exciting about what's going on. Many of you may not have heard of this, but there is a caucus in the state legislature, which consists of several people in the House and several people in the Senate who are gathered together, and they are going to be making a strong push to get the Minnesota Health Plan in Minnesota. And on January 26th, there will be a gathering at the Capitol, and this will follow the press conference which the caucus is having with the entire press corps at 10 o'clock, and there will be a rally at the Capitol at 10:30, and we're trying to get as many people as we can to the rally, and we'll be having a number of speakers. Much of this is being coordinated by HCAM. So this is an extremely important point. We've had some discussions recently, and there was a question this morning whether we have ever done this before. And I may be the person with some of the longest involvement with this, and I can't remember ever having a caucus like this that is really pushing for Medicare for All in Minnesota. So this is a really exciting time, and we are moving ahead. This is the last phase of our long journey to Medicare for All in Minnesota. Next, Jen. We have often had a day at the Capitol, and we're not going to do that this year. What we're going to do instead of that is have a strong letter writing campaign as a part of this effort to move the Minnesota Health Plan forward. And we would really welcome people to help with this. Obviously, what we would be trying to do is to write to our legislators, and we may not even know who our legislators are yet because we haven't gone through the redistricting yet. But it'll be very important to get a lot of letters to the different legislators in the Minnesota House and Senate to support the Minnesota Health Plan. So that's basically what I wanted to say. I'm really excited to hear everything that happens tonight. And in my view, I have never seen such energy in this movement, and I've been doing this for over 25 years. So I think this is the time to move ahead, and I hope everybody joins us. Next one, Jen. So with that, do you want to introduce the folks who are going to speak on these different committees, Jen?
Absolutely. So great opportunities to get involved in this new year. So you have the rally on the 26th at the Capitol. As a reminder, we do encourage everyone to wear masks. They will be required. And we will be there handing out signs there to support you in your advocacy. We'll have our letter writing campaign in March. If you don't get our newsletter, the link should be in the chat. And everyone is welcome to sign up for our newsletter to stay updated on everything happening in the Minnesota legislature in 2022. It's going to be a big year, so you want to stay informed. So make sure you get signed up for the newsletter if you're not already. Finally, we have a lot happening in our volunteer committees. And so we would like everyone to be aware of what those committees are and have the opportunity to get involved. So we are going to let the board liaisons for each of those committees just talk a little bit about what they're up to and what they're all about. And then we will have a link in the chat if you want to look at that. If you want to get involved in one of our committees, there's a form you can fill out and we'll reach out to you for that. So I can't see, do we have Jenny on the call?
Yeah, hi Jen, can you hear me?
Hi, yes.
Okay.
So this is Dr. Jenny Zhang, and she is our board liaison for our Diversity, Equity, and Inclusion Committee. So go ahead and let everybody know what's going on with you all this year.
Okay, awesome. Sorry, I turned off my video earlier because I just got home from work. The Diversity, Equity, Inclusion Committee includes myself as well as a few of our other board members at this time, Christy Atkinson, Brian Yablon, and Channing James. And we would love to have more people join us. I think it's a really important part of our work at PNHP because I'm speaking for myself, but I think probably most or all of you also have the same sentiment in that why we care about single payer is because it is a health equity issue. And we know that uninsurance or underinsurance rates disproportionately impact our BIPOC communities as well as other minority communities, LGBTQ, disabled communities. So there's just all sorts of communities impacted. And so it's important to us to make sure that our message and this and the voices of these various marginalized communities are highlighted in this fight. And that it's also important that the asks that we have in this movement are positively impacting these communities. And so to kind of tell you more tangibly what we do, we have been working on partnering with other community organizations or medical student groups to kind of reach out to various marginalized communities and figure out how we can build a coalition and partner with them in this work. We're also kind of working on modifying the talks and materials that PNHP has to specifically look at it more from a racial equity and health equity lens. And we there's going to be more talks and events that we'll hold in the future with the different groups that we are partnering with. So if my other committee members are on and want to jump in and add anything, feel free to, but I'll try to keep it short. If there's any questions, feel free to chat me or send me or Jen an email. We'd love to have more people join us on this committee.
Thank you so much, Jenny. That is wonderful. And again, just a reminder, the link to join a committee is in the chat. So feel free to click on that and submit your Google form, and we'll get you signed up for that and get you on our next committee meeting. And then Dr. Crossan is going to share with us a bit about our Education and Advocacy Committee.
Yeah, this is a sort of a combined committee that is working on developing educational programs, and much of the work on this committee is done in conjunction with HCAM. And between the two organizations, we are developing many educational programs that allow us to try to get out into the community and into the healthcare provider areas. One of the big things that's happening in both organizations is the effort to reach out to other organizations around the state. And I think there's about 25 different key allies that have been identified that we, both HCAM and us, are working on to get many of those individuals on board for Medicare for All. These are organizations that are very progressive and very likely will be very strong supporters of this movement. And this goes along with the effort in the legislature from the Minnesota Health Plan Caucus, and we're working closely with the legislators in the Minnesota Health Plan Caucus to move this bill forward. And then the advocacy is really a part of this because once you start educating people, then they want to know, well, how are we going to get this done? And this is where advocacy comes in, and it comes in by communicating with legislators and getting other people to communicate with legislators. So this is basically what we do in our committee.
Wonderful. Thank you so much. So we welcome everyone to get involved. Committee meetings happen on a monthly or bi-monthly basis, just depending upon which committee you're a part of. And so we're happy to share those details with anyone who's interested in getting involved and helping out with those great causes. So we have all these things happening, and of course it's our annual meeting, so we do have to talk about keeping everything going. Got to keep the wheels on the road. So we want to thank everyone for their support and everything they did, all of their work in 2021. And now, as we start this new year, looking forward, we do need to fund all of these great projects, these important works that are going to be coming up. And so we wanted to take a moment and just set a goal for this evening. And all of our supporters are individual donors. And that's how we keep the lights on, is just one donation at a time. And so tonight we set a goal for ourselves. We are hoping at our annual meeting to bring in $3,000. So that's a very large number, and we appreciate that. That's a lot of money, and every little bit helps. So what is that $3,000? Well, for us at PNHP Minnesota, that is one student internship. So this past summer we had 5 student interns, and students got to eat. They have to have a place to live too. So for the 8-week program that they participated in, they had a $3,000 stipend for their 200 plus hours that they spent with us this summer. $3,000 is 1 month of operating expenses. So in our virtual world, we still have office space, but we also have licensing fees, Zoom fees, professional staff time. And that is also the amount that it will cost for our consultant for our legislative outreach campaign. So to talk a little bit more about those costs that are coming with these great works of 2022, I would like to introduce first Carrie Carlson, who has been a board member for a long time. Carrie is going to talk to us about the summer internship program and what it means to the med students at U of M and Mayo Medical School, and how you can help. So Carrie?
Thanks, Jen. I'm just going to make a super short plug here. We're doing a little bit of a competition to see how many people will donate to support summer interns and support the other work that we do. Yeah, here's my plug. I guess I'm in MS1, so it will be a lot of my peers that will be joining PNHP Minnesota this upcoming summer for the internship. And I've gotten to see a lot of the interns over the years, and I just know that it means a lot to all of them. I have watched as so many of our interns have been nationally known advocates and activists, and just hearing the lessons that they all learn from even just like the language of advocacy, learning how policy gets changed, learning to be advocates on this issue and so many other issues as future physicians is just super, super important work. And having this internship here in Minnesota that other chapters of Physicians for a National Health Program around the country really look to and model their own programs after is so great. And yeah, it comes out to about minimum wage with what we pay our interns for. So really just enough to get by for the summer without taking out extra loans when school is not in session. So if you would be so generous to give to support interns this summer, I think basically every year lately it's been our biggest expense as a chapter. So I hope that we can continue this program based on your very generous donations. Thanks so much.
Carrie, you need to make a comment about the fact that you now are a first-year medical student, and so you have direct contact with the other medical students and have a particular opportunity to make an impact there.
Thanks.
So please,
you know what? There is so much fire in the medical school this year for this issue in particular. Even before hearing about our chapter, just a class of people coming from around the country to come to this medical school. They ask our professors and talk about it in our extracurricular time. You know, why don't we have a single payer program yet? So to teach those people the leadership skills that they need that already are really passionate about this issue, I think that, yeah, it's a good investment on our front as a movement.
Great. Thank you so much, Carrie. So as she said, we are, we're trying to get fired up about donating and the year ahead, and our internship program keeps growing. So last year we had 5 paid interns and we had numerous unpaid mentees that followed through the program with no pay. Med students just who were so excited about single payer and wanted to learn advocacy that they took an unpaid program with us. So I believe we had 4 or 5. So our program keeps growing. And if you want to support our summer internship program, you can follow the link in the chat. That will take you to a donation form. At the very bottom of the form, it says specialty. You can skip that and you can put summer internship program, and we'll know that your donation goes toward that particular program. So thank you so much, Carrie, for talking about that important work that we do. Next,
Jen, let me interrupt here just very briefly. We just had some discussion earlier today about the possibility of including some public health students in the graduate students in the public health program. And so this is something we may be doing further and expanding our internship efforts.
Well, I think that's great. I mean, the more voices we have out there, the better. So your donations are absolutely appreciated. Next, I would like to introduce Sarah, and she is a newer board member. She is a family nurse practitioner, and she's going to be talking to us about how we are going to support the passing of the Minnesota Health Plan and what your donations can do today. So if you want to turn your video on for us.
I think it's on.
Oh, there she is. Wonderful. Go ahead. Thank you.
Thank you. So welcome everybody. Carrie made some really good points about the summer internship program. So of course, that's a great way to donate, but we do have a little bit of a competition. And so I'm gonna talk about why you should support and donate for the Minnesota Health Plan. Again, just welcome. You know, just by being at this meeting, we know that you're personally dedicated to the idea that all people should have access to quality healthcare. But what we really need is the policy change to change our current system. We need to change the minds of the people that have the power to change that policy. So how are we going to convince them that this is an idea that's worth pursuing? Through our power of being professional voices to this issue. So it means sharing our stories, the stories of our patients, our friends, and family, and their healthcare, our health insurance woes, and our personal intricate knowledge of how to improve this system. We're more successful when we coordinate our efforts and share these stories with the legislators that have the power. So I personally am not an expert in how the legislature works. You know, we're all smart. We all took social studies, but your donation for this fund will help us be able to hire an expert in reaching those elected officials and tailoring our message to them. So please consider donating to this fund so that we can be successful and efficient in our messaging. Donating to this fund will help, you know, our end goal of changing policy. So thanks for listening, and please donate.
Thank you so much. Yes. So we will have a professional consultant who will help us as a liaison with the Minnesota legislators within the Health Plan Caucus. And that's the route we've taken in the past, just to make sure that we have our best foot forward, and that cost, the donations that you give tonight would go to support that. So thank you so much, board members, for helping out. Another great way to support our cause is to go to our Threadless shop. There is a lot of merchandise supporting single payer, Medicare for all. There's a lot to see, including masks, t-shirts, everything. And if you're looking for a custom design, we can make that happen for you. So one subject we wanted to quickly touch on, Dr. Madley will be joining us in a couple of minutes, and Dr. Crossan is going to take us through a very important issue that she's going to touch on tonight. It's very under the radar, and we wanted to make sure that everyone was informed about direct contracting entities. So Dr. Crossan, do you want to just talk a little bit about this?
Yes, in a way. It's a very disturbing situation that has occurred. Some of you may have already heard about what's happening with direct contracting entities. Under the Trump administration, there was an effort through the CMS Improvement Organization, I forget exactly what that's called, to try to move private insurance into the Medicare area. And so what they are doing is to allow organizations that are associated with the private insurance companies to move into the privatize traditional Medicare. And under this program, the organizations that are doing this are allowed to actively put a person in traditional Medicare into one of these direct contracting entities without the patients even knowing about that, and making it very difficult for them to get out of it once they get into this. And one of the downsides of this, obviously, is that under these contracts, if these direct contracting entities can make a profit, they can keep the profit. In fact, they are allowed to keep up to 40% of the money that comes from Medicare directly to them to provide health coverage for their contractees. And so this is something that is just awful. And if we allow this to happen, it will eliminate our activities, because basically what this will do would be to completely ruin Medicare. And so there's a lot of effort now, particularly by a number of organizations. I know PNHP National has gone to Health and Human Services and demanded that they stop this, and they probably will. But I mean, this is just awful. If you can imagine an organization getting a whole bunch of money to provide healthcare for people, and that organization can keep up to 40% of that if they keep the people who are there caring for away from physicians. And this is an awful situation. So this is something that we are beginning to work on, and something we have to continue to work on.
Thank you so much, John. It's a very important issue that's very under the radar. And I know that Dr. Madley is going to be discussing it tonight. So without further ado, I would love to introduce our keynote speaker for the evening. You will recognize her from last year's annual meeting. Dr. Madley is a health policy advisor and legislative assistant to Representative Pramila Jayapal. She's a former board member of SNAP, that is the student chapter of PNHP, and she was also a member of the PNHP New York Metro chapter. So Dr. Madley, we are so happy that you've joined us this evening. If you'd like to turn on your video, I am happy to send this over to you.
Thank you so much for that introduction, and it's really great to be with all of you tonight. It's great to be back with all of you. I'm really excited. And so I will just jump right in, and I would love to answer some of your questions that you all have. And I see there's the Q&A feature, so please don't be shy about asking questions. So I'm going to talk about a couple different topics tonight that are all interconnected, but they may not seem like it up front. So first, I'm going to talk a little bit about the craziness that's been going on in Congress that Congresswoman Jayapal has been involved in and really leading on in terms of Build Back Better. And I know that's not the main focus of PNHP, but I think it has some really, really good things that we can learn for the Medicare for All movement. Then I'm going to talk a little bit about Medicare expansion. Then I'm going to talk about Medicare for All, which I know is the reason why all of us are here, and really the reason that I got involved in PNHP and wanted to work for the Congresswoman. And finally, I'm going to touch on protecting Medicare because, as Dr. Crossan just pointed out, it is under attack from direct contracting entities. So to start off, the Build Back Better Act has been in the news a lot. I'm sure you've been hearing Build Back Better way too many times, or maybe that's just me. I think I need to stop saying those three words for a while. But I wanted to highlight a few key wins that I think the progressive movement had in the bill, even though it wasn't everything that we wanted. So in the bill that passed the House, there was, for the first time, the ability for Medicare to negotiate on drug prices. Now, this was not the full negotiation that we wanted. It was not as strong as we wanted, but I wanted to highlight that because when the White House released their framework for the Build Back Better Act, drug price negotiation was not in that framework at all. It was nowhere to be found. And the only reason that drug price negotiation was in the final bill that passed the House was because Congresswoman Jayapal, members of the Congressional Progressive Caucus, and most importantly, outside groups and activists like yourselves and people from Public Citizen and Indivisible and a lot of groups throughout the country were outraged the drug price negotiation was left out and really consolidated their power at that time to push back against that. And we did get that win to have drug price negotiation in there. Again, not as much as we wanted, but it was a significant win since it was originally stripped out of the bill. Another dynamic that was going on during the Build Back Better negotiations was the question of Medicare expansion. And the two things that were on the table were to expand the Medicare benefits to cover dental, vision, and hearing, which in the Medicare for All movement, we always think that, of course, your eyes, your teeth, your ears are part of your body, and they will be covered in Medicare for All, but they're not covered in Medicare right now. And so there was a huge push, and this was broadly supported throughout the Democratic caucus. Now, unfortunately, because of our friends in the Senate, Senator Joe Manchin and Kyrsten Sinema, who were against Medicare expansion, only the expansion to cover hearing benefits was in the House-passed Build Back Better bill. But I think it's very important to recognize that if we could get Medicare to cover dental, vision, and hearing, we can get it closer to the program that we envision as Medicare for All and just strengthen the program rather than tear it down like the direct contracting program is threatening to do. Another piece of Medicare expansion that Congresswoman Jayapal was leading on was lowering the Medicare age. And this is another proposal that is incredibly, incredibly popular. It has the support of 60% of all voters, including 75% of Democrats. And we pushed as hard as possible to lower the Medicare age in the bill. Now, we did not get that in the final bill, and you may be wondering why I'm highlighting that as somewhat of a success. And the reason I think that was a bit of a success is because we further built the movement for supporters of Medicare and strengthening Medicare. So we introduced a bill in the House that would lower the Medicare age to 60 and also strengthen the Medicare Savings Program, which is the program to help low-income beneficiaries. And that bill has 136 co-sponsors in the Democratic caucus, including co-sponsors who are on very, very powerful committees like Education and Labor. And we also have a lot of frontline Democrats on the bill. Now, these are Democrats who come from districts that are very purple, if you will. They can flip back and forth to Republican and Democrat very easily. And one criticism of Medicare for All, although it is unfounded in the polling, is that folks in frontline districts are not supportive of Medicare for All. So what we have really been trying to do is build a broad coalition of House members who are in the Congressional Progressive Caucus, but who are also in the more moderate wings of the party to get them to support things that will get us closer to Medicare for All. Because when we're talking about lowering the Medicare age, these members are often telling us, my constituents love Medicare. They just want it earlier. They want to be on Medicare as early as possible so that they can be certain that they'll have health benefits, so they can retire if they need to. And a lot of those talking points are very similar to what we talk about when we talk about Medicare for All. And so if we can build this movement and then shift it into broader support for Medicare for All, that's going to get us closer to the end goal. So I did just want to touch on Build Back Better because, again, recognizing it is not the end goal. The Congresswoman has been saying that, and I know a lot of the groups have been saying that, and PNHP has been saying that, but it is a step on the way to that goal. So in a similar vein, I wanted to talk about Medicare expansion because I think it's something that will come up a lot, especially as we go into the 2022 midterm elections. So as I mentioned, it's a broadly popular idea. And one thing that we may see in this next year in Congress is trying to make progress and pass a bill that would lower the Medicare age. And again, we see that as a Big Tent approach, if you will, to bring more people into the Medicare for All movement and really to find that common ground of really liking what Medicare has to offer while recognizing that it's not perfect, right? Medicare still does have copays. It still does have deductibles for some of the parts. It still does have things that we do not want to see in a Medicare for All system. But if we can find common ground with people who really like Medicare and then expand from there, strengthen the program and get to a Medicare for All system, that is going to help us just grow the movement outside Congress, but also inside the halls of Congress. And so we will be looking at, how do we move this forward while continuing the Medicare for All fight within Congress. So now I'll get to Medicare for All, which is why we're all here. And I am excited to share that recently we had an additional co-sponsor sign on to HR 1976, which is the Medicare for All Act of 2021. The bill that the Congresswoman leads. And so the bill now has 118 co-sponsors. And this is a special number because this is the maximum number we got to during the last Congress. But we're only halfway through Congress this time. We still have an entire another year to build co-sponsorship. And I really do believe that we can get over 118, we can get to 119, which will be the record amount of co-sponsorship for the bill. But I do think we can get even further than that. And I think it is really telling that we got to the number of co-sponsors from the last Congress in half the time in this Congress. And so we are really excited to keep moving forward on that and reach a new record of co-sponsors. Now, you may be wondering why co-sponsors from the last Congress all didn't get on the bill for this Congress. And there are a few offices that were on the last time and didn't get on, but a lot of that turnover is from retirements or folks choosing not to run for Congress and either, being in the Senate or other elected positions. So we are really happy to be at 118 right now. And the 118th co-sponsor was Representative John Garamendi from California. And I share that because there was a huge, huge grassroots effort with NNU, with Indivisible, People's Action, and PNHP, I believe, was involved out there, really, really talking to Representative Garamendi about why they felt they really needed Medicare for All and they wanted him on the bill. And it was not an easy process to get him on the bill. It did take a while, but I think it just goes to show the power of the outside organizing that you're all doing, and it is making a difference in Congress. So that was really exciting. Now, thinking about this next year with Medicare for All, the Congresswoman is really excited to keep building the legislative record for the bill. So we are looking to hold hearings and public events, but also to talk about Medicare for All in public spaces as much as possible. So even if it's a hearing that's not specifically on Medicare for All, a lot of things can be tied back to the health inequities that we see in our current system. And we want to be talking about that, and we want to be getting that message out. We also want to be, again, growing the movement and not only getting more co-sponsors on the bill, but building relationships so that we can have more vocal champions of Medicare for All in Congress, because we don't want people just to sign on to the bill and then, sit back and relax. We want them to sign on, and then we want them to be pushing in their committees to have a hearing. We want them to be talking about Medicare for All whenever they get the chance to. And I think we are on our way to doing that. And one way that we can see that working is through the Congressional Progressive Caucus. So for those of you who don't know, Congresswoman Jayapal is the chair of the Congressional Progressive Caucus, or CPC, as people call it. And the CPC changed its rules going into this Congress to better consolidate power. So rather than being an ideological caucus to discuss bills that needed to move, but not being able to make a lot of headway because it's very hard to be a progressive in Congress right now, they changed the rules so that they could make headway. And so now the caucus has the power to vote as a block. They have the power to require that their members are actually on flagship CPC bills, so that members aren't, joining the CPC just to potentially avoid a challenge, a primary challenge, or something like that. And I think that power has really been seen in the fight on Build Back Better, which the Congressional Progressive Caucus led the fight to make sure that Build Back Better passed the House, but also with Medicare for All, because we are, again, building a coalition within Congress. And I think that's one of the great things that Representative Jayapal brings to Medicare for All is she was an organizer before, and she really brings that organizing into Congress. So my job, although I'm not, working for PNHP and with SNAP anymore, as a member, I am still getting to do organizing, but now it's just inside Congress. And I think that's really special about the Congresswoman, and why I think it's great that she's leading Medicare for All, because we do need that type of strategy for this type of bill. So I'm going to move to my last point, and then I would love to discuss questions and comments that you have. So we've been working really hard, as I know PNHP has, on protecting Medicare from those direct contracting entities, or essentially we view it as an attempt to privatize Medicare and bring in private insurance companies, private equity companies to administer Medicare beneficiaries' benefits to them. And so we are very, very concerned about this. And we actually recently, the Congresswoman sent a letter to Health and Human Services Secretary Becerra, as well as the Center for Medicaid and Medicare Services Administrator Chiquita Brooks LaSure. And this letter requested that they stop both of the DCE programs immediately, and they transition those beneficiaries back into normal fee-for-service out of their direct contracting entities. And this letter had 54 co-signers, which we were very excited about. And again, it was not just CPC members who were on the letter, it was members throughout the Democratic caucus, which just makes what we do even more powerful. And we are currently taking next steps to make sure that we are ending this program and continuing to push for its end, but also thinking about, are there steps that we can work with CMS to take to get us closer to a single payer system and make sure that these types of ideas are not just popping up with another name and still getting into our Medicare system. And I do want to say we were really excited to have Congresswoman Ilhan Omar on the letter, who I know is from Minnesota. So we were very excited to have Minnesota represented on the letter as well. So I will pause there for some questions, and I see a lot in the chat. So I will just kind of go through these. I'd be happy to talk about them. So I see one question is talking about asking, has there been any blowback from patients yet? Because DCEs started this month. So there are some new DCEs that started this month, but there are a lot of DCEs that started actually last year. And so we know from the companies that are running these DCEs that unfortunately, these are similar companies that run Medicare Advantage plans. And what we've seen is that when folks get critically ill and need end of life care or more acute care, and to really use their Medicare benefits, they actually have to shift out of these MA plans back into traditional Medicare. And so that is one of the main concerns there. And I do know that often physicians who work in coordinated care settings like a DCE that has either a private equity investor or another private investor often report that their patient care does suffer because they are told, we're cutting nursing staff, we are trying to save money, and they're really incentivized to cut cost rather than to treat the patients. So that's a really good question. Let's see. So I see there is a question about, do you think the single payer movement in California had influence with Rep. Garamendi signing on to HR 1976? I definitely do. And this is something that I get asked about a lot, state versus national Medicare for all. And I think when it comes to organizing and educating, whether you're working on a state bill like CalCare or a national bill like HR 1976, we're talking about the same thing at the end of the day, right? We're talking about the right to healthcare without any obstacles due to cost or insurance networks or anything like that. And the state bills are set up in a very, very similar way to the national bills. Now, the payment mechanisms might be a little different if you really get into the weeds, but I think the organizing that we do around Medicare for All is building the movement no matter what bill specifically we're organizing around. And so I definitely think it had an influence and likely helped get Rep. Garamendi on the bill. Oh, this is a good question. So the question is, one criticism I've heard for lowering the Medicare age with Medicare Advantage still in play is that so many of the younger and healthier enrollees will become Medicare Advantage enrollees and further privatize Medicare. Has this been discussed by the Congresswoman? So this is definitely something that we've been thinking about. And one reason that in our bill we lower the age, but we also improve the Medicare savings program is to strengthen Medicare. The other thing that's really important is that we in Build Back Better, we're pushing for lowering the Medicare age and expanding benefits to dental, vision, and hearing to further cut down on the perceived differences between Medicare and Medicare Advantage, because Medicare Advantage likes to upcode on their patients. And so they will make their patients seem sicker than they really are. They'll get a really big payment from Medicare, the Medicare Trust Fund, to Medicare Advantage. And then they use the extra money, a part of it, to offer what they call, dental and vision benefits. Now, those dental benefits are not robust. They're usually a cleaning and a checkup once a year or something. And they take the rest of that overpayment for profit, but they are making themselves seem like they offer more benefits. And so if we expand benefits to dental, vision, and hearing, if we strengthen Medicare, I don't believe that that will be as much of an issue. This question hits on something else that can get us into the weeds very, very quickly, but we also believe that we need to make sure that we are stopping that upcoding by Medicare Advantage, because economists have shown that we overpay Medicare Advantage by hundreds of billions of dollars every 5 years. And so we need to cut down on that profiteering. So that's a great question. And I think it's a combination of things that the Congresswoman is working on. I see another question. How is the DCE model different from Medicare Advantage? And that kind of hits on what I was talking about. So the main difference is that it's a traditional Medicare beneficiary in the DCE and not a Medicare Advantage beneficiary. Other than that, they are very similar, which is part of the cause for alarm. So in a DCE model, as I mentioned, for Medicare Advantage, and I know this gets a little bit wonky, but in the DCE model, the direct contractor, whoever they are, for example, Humana owns one of these DCEs, so I'm going to use them as an example. Humana has a patient. They will submit the risk score for that patient, so how healthy or sick they are in comparison to an average patient. And then they will get either a partial or full payment for all of that patient's care. This is exactly what happens in Medicare Advantage. And then anything that they do not spend on that patient's care, but that's part of the lump sum that they got, they can keep a very large chunk of that amount. And so it really takes us away from the fee for service, but also gets us very close to Medicare Advantage and draws in more private entities. So great question. They are very, very similar. And one of the concerns is that Medicare Advantage plans are going to specifically advertise to patients in DCEs to get them to come over to Medicare Advantage, because the same companies that run a Medicare Advantage plan are running a DCE, and they can make even more money if it's a Medicare Advantage patient. So why are they not going to target advertising and say, hey, come on over to our Medicare Advantage plan? So that hits right on one of the concerns. Let's see. Oh, so I see one question in the chat. What was the argument made when DCEs were being established? So this is something that I think we could use as a strength in the movement. So DCEs were actually created in the Center for Medicare and Medicaid Innovation. And under the Affordable Care Act, the law gave that center broad ability to conduct experiments, if you will, on different payer reforms. And so when this payer reform was presented during the previous administration, the goal that was presented publicly was to better coordinate patients' care. Now, obviously, that was not the only goal, because there was an article actually about how there are severe ethical concerns with DCEs because some HHS personnel were set to profit from the creation of specific DCEs. And so that was not likely the main goal, but the public goal was for better coordinated care. Now, you can achieve better coordinated care through many other means than pulling in private insurance companies, private equity companies, things like that. But I mentioned that this is an opportunity for our movement because CMMI can do other types of experiments that get us closer to Medicare for all, right? So there's an experiment that they've been doing in Maryland for decades on global budgets. and global budgets are part of HR 1976 for hospitals. So it's very interesting to think about, is there something that we can do that's a little more constructive than privatizing Medicare? And I think there's a lot of things that are more constructive than that.
Rachel, may I just interrupt you for 1 second? I just wanted to point out, we've been putting in the chat, we have a generous board member who is matching donations until 7:30 p.m. So you've got about 5 minutes if you'd like to make a donation and have it doubled. We would appreciate you. There should be a link in the chat that you can follow. And we still have 5 minutes with Dr. Madley, so feel free to submit your questions. So thank you so much. This has been great.
Of course, and thank you to that member. That is so fantastic. I'm just going to take a quick second, a point of personal privilege. So I would not be in the position I am today without PNHP and SNAP. I heard you talking a little bit about your internship program, and I actually did a student fellowship with PNHP in New York Metro, and that really just gave me the knowledge I needed, but also kind of ignited my passion for Medicare for All. And so PNHP is very near and dear to my heart, and I think the donations go a really, really long way. So I just wanted to add that because I would not be here in my position without this organization. So I did see a question that is a fun thought exercise that I think about sometimes. Could DCEs work if the insurers were taken out of the loop? It's a really good question, and it's possible that they could. And I think they would be more like accountable care organizations or ACOs at that point. Insurers and private equity investors and the bad actors who own DCEs, if you will, are part of the main problem. There are a few other problems with DCEs in terms of risk scoring and things like that. But if insurers were taken out of the loop, like many things in our healthcare system, it would solve a big part of the problem, but not the entire problem. Okay. And so I see a comment from a doctor who cares for elderly patients talking about the coordination of care is really critical, but it's not done very well in Medicare, but Medicare Advantage and DCEs don't do it well either. And I could not agree more. I think, as I mentioned before, the involvement of for-profit insurers and for-profit entities in our healthcare really complicates things a lot, because the goal of many people in CMS is better coordinated care. But, all of these models get infiltrated by for-profit entities that just completely change what the goal of the program is. And we need more coordinated care without the role of those for-profit entities. And so I'm hopeful that CMMI will be open to trying some models like that, so that we can get away from the privatization of Medicare, because it is very dangerous. And I see a question about public options. So my perspective on the variety of public options. So I'll just touch on this, and then I know we're close to time. What I can say about public option is the Congresswoman, as the Medicare for All movement, it is wholly supportive of going to Medicare for All first. We think that the public option has a lot of downfalls and issues. The Congresswoman was part of the Biden-Sanders Unity Task Force on healthcare with Dr. Abdul El Sayed, who I know has spoken at some PNHP events as well. And what having their voice there was really, really helpful on is this discussion on public option. So I can share, my perspective. I think that public option is not the way to go. But if we find ourselves in a political moment where it's a certainty that public option is going to happen, we need to make sure we're at the table so it's a truly public option. We cannot have a public option that somehow involves private insurers like they're trying to do in Medicare, because I truly believe that would be a really, really big step back on the way to Medicare for all if we try a public option, but it just increases the presence of for-profit insurers. So I think we need to fight as hard as possible so that we get to Medicare for all and not a public option. But if a public option is going to seriously be on the table, no matter what we do, we need to stay at the table to make sure that it's not a step back and it's just a tiny step forward on the way to Medicare for all. And I know that's difficult to do because it's really, really frustrating, because all of the facts are behind us. All of the patient stories are behind us. All of your expertise on the front lines every day is behind us needing Medicare for all. But if something like that happens and, public option again is being seriously considered, I think we all need to be at the table to make sure that it's not the disaster that it could be. And I will leave it there.
Actually, Dr. Madley, that is a fantastic segue to our next part of our meeting. So I'm
perfect.
I'm glad you said all of that, and we will be moving towards the next part of our meeting, which will be a presentation by our two summer interns, Zelda Blair and Alex Jacobs, on, guess what, the public option. They spent 7 weeks studying the public option. And so while they're getting ready to share their slides, I just want to provide a bit of an introduction. And I want to say also that after their presentation, I'm going to talk about an article that I just heard about today. And I'm going to talk about that after they finish their presentation.
John, may I just break it?
Oh, I'm sorry. I'm
not sure if Dr. Madley is available to stay with us. So I just wanted to make sure that we said a hearty and humble thank you for sharing your time with us tonight. Yes, thank you. We appreciate you, and we're proud to know you, and just seeing the places that you are going and the great things that you're making happen. Just bravo. So thank you so much. And yes, we're going to transition now into our panel discussion.
Well, thank you so much. Thank you so much for having me. I do have to jump off, but I really, really appreciate it. And I look forward to talking again soon. Thank you, everyone.
Good. Wonderful discussion. Thanks.
Thank you.
So I do just want to tell the audience that unfortunately, it is important for us to know something about the public option. And first of all, we can't call it the public option because there are many, many different kinds of public options, and they all exist in different colors and flavors. There is one public option that I've heard about that does require that everybody who is uninsured immediately get put on the public option if it's adopted. And what that does is to, quotes, provide some medical care for everybody. And so that accomplishes one of our objectives. However, it doesn't accomplish all of our objectives. And so I'm going to turn it over now to Zelda and Alex, who worked on this for 7 weeks last summer. And we're anxious to hear what you have to tell us. Go ahead.
Great. Thank you so much, Dr. Crossan, and thanks to everyone at PNHP for having us. It's really, really great to be here presenting again this work that we did over the summer. So I'm Zelda. I'm a second-year medical student, and this is Alex, my co-lead on our presentation that we created over the summer as PNHP interns. So we were very, very fortunate to benefit from that program. I know how much it meant to me to get to learn more about this and be supported in the process. We heard from some amazing speakers, some of whom are on the call tonight, I think. So thank you again to everyone who was part of that for us. So I'm going to start off here with sharing the slideshow that we made with you all and talk a little bit through what we learned over the summer about public options, what the good, the bad, the ugly, what they can look like. So I'll start off with the best case, what we could expect from a public option were it to be the ideal form. So just first of all, the term public option, as Dr. Crossan mentioned, is notoriously difficult to pin down, and people often use it to describe plans that are actually very different. So here we're going to define it as having these basic ingredients. There are a lot of other ways it can be defined, depending on who's using it, but basically individual mandate means that everyone has to be insured, and guaranteed issue means that it has to be offered to everyone. So no turning people away for any reason, no dropping or dumping patients. And then these other important aspects are not included in many state level plans, mostly in international examples, and would probably be very difficult, if not impossible, to implement on a state level, even if they were put into public option bills. But mandated minimum benefits is probably one of the most common ones that's included in state level plans. And I'm not going to go into a lot of detail about those, but can answer questions later if there are any. So these components we would think of as being necessary to include, as Dr. Madley mentioned, if we were to find ourselves at the table thinking, okay, what do we really need to have in a public option if that's what we're looking at? The first one would be competitive coverage. Obviously, we want to have the best coverage possible, really competitive benefits, and this would ideally be something that insurance companies would then struggle to compete with. And part of that would be mandating that providers accept it, so patients can take their public option insurance wherever they want to take it. It would also have to explicitly exclude the possibility of subcontracting by private insurers, as we've seen with the discussion of DCEs and Medicare Advantage. And Alex will talk more about this. We can't allow the public option that we would have to become another version of Medicare Advantage. So the final aspect would be some amount of reduction in administrative costs and an improvement of public accountability. And these are, currently in dismal state based on the current system. So a public option would ideally at least improve these to some extent. Unfortunately, there would still be these certain problems that we would expect even from the ideal public option compared to Medicare for all single payer. So even with strong price capping, a multi-payer system is going to have some amount of administrative weight, and eliminating this is a major way that single payer would save on costs. And implementing even a more efficient billing and record system to reduce administrative waste would be also valuable, equally valuable under single payer. So there's really no reason that we would use that just to prop up an industry that can be replaced by Medicare for all. Public accountability is also a major issue that can only really be adequately addressed with Medicare for all, because as long as insurance companies are involved, they'll be primarily beholden to their shareholders, not patients and not the public. And in the United States, we are all well aware of the dense layers of inequality that we have in access to all resources that need to be redistributed fairly without relying on market forces to do that, which only entrench our existing disparities. So this portion that we have here on progressive versus regressive financing is a bit technical, but it basically means that currently we have a regressive system in which poorer patients pay a larger portion of their income for the same services with fixed premiums. So Medicare for all would be restructured to be the opposite of this. So under progressive financing, we would have wealthier people paying more for the same services as one way to more equitably distribute the resources that we have. Next, I want to outline a few of the reasons we found for why people support public options and address these. And the first one is just all the misinformation about Medicare for all. It's groundlessly attacked as being socialized medicine when in fact, hospitals and clinics would remain private, not government controlled. Those on Medicare are sometimes opposed to Medicare for all because of misinformation about its impact on their access to services and their current benefits, whereas in fact, adding more patients and younger patients to Medicare would in fact strengthen it. And the question was mentioned earlier about concerns about Medicare Advantage, and certainly we would want to prevent that from happening. Another reason that some businesses support the public option is concern about this slippery slope that it would open the door to government regulation in other industries. So Medicare for all would affect businesses differently based on their size and their wage level. So part of the issue with business opposition is misinformation about that. In fact, most businesses would quite significantly benefit from Medicare for all, while a public option wouldn't really to the same extent. There's also concern in the health insurance industry, of course, about loss of jobs. But this is provided for both in the federal bills that we have Jayapal and Sanders, as well as the state level bill, Senators Marty and Frazier. And those employees in the insurance sector would, of course, benefit the same way all workers would, much more from Medicare for All than from a public option in the long term, because of the effects of high insurance premiums on preventing increases in their wages. But more fundamentally, healthcare is not really the same market good that other market goods are. So there's no reason to assume that government intervention in this sector would extend to any other. Sorry. Okay, so the next reasons we wanted to address, the first is sort of physician specific, about compensation. Certainly the highest compensated specialists would see some reduction in their compensation with Medicare for All, and there are some ways to mitigate that, but it's also to some extent part of the package. For all physicians, there's certainly reason to choose not to just add another payer to the mix. That would do nothing to reduce the administrative weight that's so expensive and time consuming for providers. And then some people support a public option based on examples from currently existing state level or international successes. And unfortunately, in general, the state level examples that we've seen don't have quite enough detail about how practically the public options they propose would be implemented. And there's really only so much that could be done without federal support. The international examples are pretty fascinating, and we learned a lot about those over the summer, but it's very difficult to compare in different contexts, and of course, not very popular to do so. And the final reason here that I've actually found to be the most compelling reason for the public option support is this last one, that incremental reform seems more realistic in terms of congressional approval and public support, that it's just going to be impossible to quote unquote ban insurance companies, and that public options would at least be some improvement and would be a stepping stone to Medicare for All potentially. But the problem with this, I think, is that it's, and Alex will present more on this later too, that it's historically, we've seen that it's also probably as unrealistic to try to get a public option to get us to Medicare for All incrementally. There's kind of a point of no return here that we need to just get for-profit insurers out of healthcare. As has been mentioned several times, the incentives are totally backwards because insurers are working to avoid taking care of sick people. They are trying to avoid taking care of patients and paying for that care in order to turn a profit for their shareholders. And so the basic premises are just at odds. And now I will turn it over to Alex to talk about half of this.
If you go to the next slide. Cool. So this has been talked about a lot this evening, but I wanted to sort of take a detour and argument here for Medicare for All over the public option. I want to first take a detour through some of these privately administrated ostensibly public plans that we have in this country, whether it's Medicare Advantage or direct contracting entities. And one of the trends we see through all these different so-called innovations in payment is that they turn into just a new windfall for private insurers who have the means to write the rules in their favor and to control these markets. Medicare Advantage, famously was touted as a tool by which we could induce competition in Medicare markets. It had the opposite effect. And overall, Medicare Advantage, this has been talked about this evening already, is a program that is overly expensive, results in overly expensive care, and is no more efficient than traditional Medicare that is intended to innovate upon. Could you go to the next slide, please, Zelda? And Dr. Madley talked about this better than I can, but direct contracting entities are really just variation on the Medicare Advantage theme. And I bring this up because although these are not public options, it introduces the sort of danger that we see that's inherent in any kind of private administration that could be in some of these public option plans, not in all public option plans, but when private industry, when the insurance companies have a seat at the table when it comes to administering ostensibly public plans, they have a way of reducing care for patients and padding their pockets. I think that this can be summed up with a quote that I saw in the chat earlier from Rose Roach that I loved, was Medicare for all becomes meaningless if the medical industrial complex ends up owning, running, and profiting from our Medicare system. We absolutely must stop this privatization of traditional Medicare. And I think that's something to hold as we think about public options too. I agree with something that Dr. Madley said, which is if there's a guarantee that there will be a public option passed, we should absolutely have a seat at the table, but that shouldn't be the goal that we pursue most, at least at the moment. Next slide, please. And so, yeah, this is the incremental reform argument that we wanted to touch on again. There's a great piece, I'm sure many of you have seen it, in the New England Journal from a couple months ago, where Hacker lays out like one of the better sort of public option models that was really seductive in a lot of ways. And I think that it speaks to a lot of people's urge for incremental reform, the urge to not rock the boat, the urge to not get rid of insurance companies. What does that mean? You know, there's so much that's unknown in Medicare for all that the public option might seem like the safe option. But one of the things that we noticed that we learned over our summer of research was that whenever there's state level attempts at public options, whenever there's, you know, a federal fight like there was for a public option under the Affordable Care Act, there's still this like bare knuckle fight that occurs from private industry and their backers in Congress over the public option. So it might seem incremental to those of us who are sort of maybe on the fence, but like we want healthcare reform. But it's just doesn't seem like incremental change for the private industry that seeks to control these rules. And so if we're going to have a fight over something in Congress, you know, my argument is we should have a fight over Medicare for all, because that's going to ensure the greatest equity and the greatest care for patients across the country. It touches every single person. And history shows again and again that if private insurers have a seat at the table, they will find a way to turn the table in their favor. Next slide, please. I literally just said this, so next slide. Cool. And so I want to talk a bit about public opinion here. So both Americans, this was actually, Dr. Madley mentioned this as well. Americans, like the polling is on our side when it comes to Medicare for all. The majority of people in this country are in support of something that looks like Medicare for all. A majority of people that exceeds the majority of Medicare for all support the public option. Public option polls more favorably. And I think that's important to acknowledge, and that's an argument in favor of public option. But I'm really encouraged by the polling that suggests that people are in favor of both these plans, because either is a positive step. And I think that this should be encouraging, even if there's a lot of industry opposition, that voters are, you know, intrinsically like at a baseline on our side. We go to the next slide, please. And I think something else to keep in mind is that this is polling again from Kaiser Family Foundation, is that voters can be swayed. So if on the previous slide we saw that there's a slight favor for public options over Medicare for all at a baseline, patients or voters are also very malleable in their opinions when it comes to the public option. And I think this extends probably to Medicare for all. I think we can make that safe assumption. And this just increases the need for organizing, increases the argument for messaging in a way that gets people to understand the benefits of both these programs, and ultimately to support Medicare for all, because all of the data show, as Dr. Madley pointed out, that like Medicare for all, it solves many of the issues that we face, and we can sway people's votes in that direction. Next slide. And this is, I think, at the end of the day, the argument that Zelda and I came back to at the most fundamentally is that, you know, what is your values? This is an ethical question more than an economic one. This is an ethical question more than a political one. Is healthcare good, or is healthcare right? And if you believe that healthcare is the right, Medicare for all is the answer. Yeah, thank you.
Thank you so much, everybody. We'd be happy to answer more questions at the end, and I see a lot in the Q&A, so we'll see whether we're going to answer those now or what the next plan is.
Before you move towards that, I want to tell about the article that I just heard about a few hours ago, and I've had a chance briefly to skim it. And actually what Alex said is a perfect segue into talking about this article. It's not necessarily going to be an article you're going to be happy about hearing about, because the title of it is Medicare Advantage for All, a potential path to universal coverage. This was published in the first issue of this year's JAMA, and the reference to this is actually in the chat. So people, I would actually encourage people to read this. It's a very disturbing article in many ways because it's written in a fairly convincing way, as many of these articles are. But if you look at the very beginning of this article, what he seems to be concerned about is the future of managed care organizations. And he's afraid that if we don't do this and we go to Medicare for all, the managed care organizations are going to suffer. I don't look upon this as an argument for Medicare Advantage for all. There is one potential positive there, because what this plan that he is putting forth would do is to separate a patient's health insurance from their employment, which is a very, very positive move. But I just wanted to mention this and encourage everybody on this call to read this article, because this is what we're going to be facing also. So it's going to still be an uphill battle. Well, now I'll open up for questions. Thanks. Great job, guys.
Thank you, Dr. Crossan. Yeah, I'm just looking through the chat and the Q&A. Thank you, everyone, for your support. Yes, Medicare Advantage for all, a pile of garbage. I would agree. At best, might be more dangerous than a pile of garbage. There's a question about the Waltz administration specifically. I'm not really sure if I can answer this, but if anybody else has a thought, feel free.
I think he has, to some
part of
extent,
that.
Yeah, I think he's come out to some extent in favor of the public option. I don't know how strongly he feels about that, and Rose may actually know a little bit more about that than I do. Maybe she could put something in the chat. Rose, you want to put something in the chat about that?
Given what Rachel Madley was describing earlier, also about the push in California to get their representative to sign on to the bill in Congress, that's a good example of the kind of thing we need to be focused on, I think, and why I and the rest of our SNAP chapter at University of Minnesota are hoping to attend the day at the Capitol coming up at the end of the month to push legislators to show them that this is something that we want in every way that we can. It's hard to do that virtually, of course, so it'd be good to be there in person and have a chance to wear our white coats and show them that we're there because we want that. We want them to support us.
Rose did reply. She wrote, Governor Waltz definitely supports a public option. That's what his one care proposal from the 19 to 20 session was. He currently supports HF 11 and Rep. Jen Schultz's public option bill.
Right. Yeah, that's what I thought.
Yeah, we didn't talk too much about that bill in our presentation. I don't know, Dr. Crossan, do you want to talk a little more about the differences between what you understand differences?
Well, it's supposedly just an expansion of Medicaid, which does become basically a public option. At least that's the way I understand it. I may not have that completely correct, but it is just it's an expansion of Medicaid that looks like a public option.
Wonderful. Well, I think, oh, Pester, your elected representatives. Thank you, Mark. Yes, absolutely.
Well, I just want to thank Zelda and Alex again. I think they did a fantastic job, and they incorporated a tremendous amount of information into a very, very timely and important presentation. So we want to thank you very much.
Thank you. Once you start learning about public options, it's hard to know where to stop. So this presentation would have been a 6-hour workshop. I think it's a lot to learn, but we were, like I said, extremely fortunate to have a whole summer to delve into a lot of these issues. Thanks to the generosity of everyone who's donated. That's going to be an opportunity for students this summer too. So thanks again, everybody.
Yeah, I just want to say thank you. It was the most fun part in my first 2 years in medical school, getting to dive into some of these. So appreciate everyone's generosity.
Well, I just want to mention, since you said that, Alex, that you had some insight into the passage of the Affordable Care Act. You want to expand a little bit on that?
I don't know if I could call it insight, but I interned at the Senate. I'm like old for a medical student, and I'm in my early 30s. And so when I was in college, I interned for Senator Bob Casey when we were working on Affordable Care Act implementation. So I got to see some of the implementation, all the battles that were being fought over who got to administer what different plans, and got to see how the sausage was made, which was a great experience. But that's I then pivoted to medicine. So
so Jen, we'll turn it over to you.
Well, I also want to thank Zelda and Alex for their time tonight and for sharing all of the things that they worked on over the summer. Hopefully this is a good way for everyone to see this program. This was a half of their internship with us, their summer internship. 100 hours were spent on this independent project, just delving into the public options. And then the other 100 hours was spent with reading and talking with advocates. And so it's a big program, and we're very proud of it. And it was a part of our big donation ask for the evening. So how did we do? Our evening goal was $3,000, and tonight we raised over $3,800. Thank you to all of our members and all of our guests tonight for your generosity. This is fantastic. I'm feeling a little emotional about it. I apologize. So thank you so much for everyone for your support. It means a lot. We hope that you enjoyed our evening tonight, and we want to thank you, members and partnering organization members, for joining us. We will be sending out links and contact information and the link to the video recording of our session this evening within 48 hours. So look at your email, watch for that, and feel free to share that with anyone that you feel like might be inspired by the things that were discussed tonight. There will be a survey that pops up when you leave our session tonight. Thank you for sharing your comments, and that's how we keep making programming that is relevant to our members. So be sure to complete that survey, please and thank you. If you have any questions, feel free to email us at pnhpminnesota@gmail.com. And one more time, we want to remind everyone, don't forget to mark your calendars. We want to see everybody that is available at the rally on the Capitol steps. Please arrive by 10:30 a.m. And that is Wednesday, January 26th. Don't forget your signs. And again, make sure you mask up. So thank you so much. We really appreciate everyone for joining us tonight.
Are there enough questions for? No, I'm just going to ask, are there enough questions that we could stick around a little bit more and address more questions?
Yes, absolutely. We will stay online a little longer tonight, so feel free to stick around, or else this is the end of our presentation. So thank you again, and everybody have a really great night.
So can somebody get into the chat and see if there are any other questions that we might want to try to answer?
Yes.